So I began my career in medicine a long time ago. Back in the 1960s, we were concerned that rising healthcare costs were going to take the GDP up to 8%. Wow, that was unsustainable. Soon it was going to hit 10%. Well, of course, you know what's happened since then. And over that time, I practiced in internal medicine in a variety of settings. I ran a national foundation focused on improving health and healthcare, and worked in academia on a variety of healthcare and public health issues, including most recently smoking cessation. And I can tell you that the rising costs of healthcare has always been a personal concern. But I think we're now at a point where the level of spending on healthcare is unsustainable. It's unsustainable. I said that in the past and I was wrong. I don't think I'm wrong today, but if I am, you can tell me in a couple of years. The way that doctors are paid is one of the single most important drivers of our escalating healthcare costs. That is why when SGIM came to me to head a commission to recommend real changes in how physicians are paid in both public and private sectors, I seized the opportunity. SGIM, and in particular Dr. Harry Shulker, who was serving as president of the society at that time, felt that the nation needed a thoughtful and focused discussion of this topic, but recognized that only an independent commission that incorporated the ideas of payers, administrators, business leaders, and consumers, as well as specialists and primary care doctors, could have the credibility to issue the recommendations that our commission is telling you today. So that is what we put together. We naturally turned to Senator Frist, you're going to hear from in just a few minutes, given his experience as a surgeon in the healthcare system, his incredible leadership skills, and his vocal interest in doing something to rein in health costs. We asked the senator to serve as honorary chair. We were able to recruit a group of commissioners, and you're going to hear from some of them, whose collective expertise and leadership of our healthcare system is unrivaled. I want to thank Senator Frist and the other commissioners who are in the front row for their participation, their thoughtful approach, and their commitment to delivering a bold plan for improving our physician payment system. After a year of consultation, the Commission prepared 12 recommendations for reforming how doctors are paid across the entire marketplace. I'm going to touch on them briefly here. There's far more detail in the full report, but I want to highlight what we see as a real roadmap for changing how doctors are paid. Inherent in the recommendations is the need to move the country towards forms of payment that have a quality component and that spread risk across all the providers. Our current payment system, which is dominated by fee-for-service, is fundamentally flawed. Fee-for-service offers skewed incentives that promote fragmented care and encourages doctors to provide more and more costly care, regardless of the benefit to patients. We need to change this. That's why in our first recommendation, the Commission calls for phasing out fee-for-service so that by the end of the decade, we will have a mixed payment model. What we mean by this is a broad adoption of fixed payment mechanisms like capitation and bundled payment, with fee-for-service playing a more minor role. While the long-term vision is to eliminate fee-for-service, the Commission recognizes the reality that there are instances, even within fixed payment models, where it makes sense to pay an individual physician on a fee-for-service basis, at least in the interim. The following recommendations provide a blueprint for this transition over 5 years. We must begin by accelerating new models of care, such as accountable care organizations and patient-centered medical homes that reimburse doctors through fixed payments and shared savings. The Commission recommends that we start the implementation of these models by focusing on areas with a significant cost-saving potential, such as patients with multiple chronic conditions or for in-hospital procedures and their follow-up. During this transition period, we also recommend a number of improvements to fee-for-service. These include rebalancing the inequity between the evaluative and management aspects of care and care that's done with giving a procedure. By increasing the reimbursement for those E&M services and freezing reimbursement for doing a procedure. This recalibration could have beneficial results on the distribution of physicians by making the E&M specialties, including but not limited to primary care, more financially compelling. We also recommend doing away with differential payments for care based on where it is provided and by who. It makes no sense to pay more for an echocardiogram that's performed at a facility owned by a hospital than when it's done in a freestanding doctor's office. Within the Medicare program, we recommend that the SGR adjustment be eliminated because, simply stated, the SGR hasn't worked in practice and it shows no prospect of ever working. We also recommend drastically revamping the RUC while at the same time putting CMS on a path so that it could independently, in addition to the recommendations from the RUC, source the information it needs to set reimbursement rates for doctors under the Medicare program. We've set forth a bold charge to phase out fee-for-service with an ambitious time frame. Everyone agrees that we must rein in health spending. We hope our recommendations offer a starting point, one which contributes to the national dialogue in Congress and among healthcare providers and payers. I want to thank the Robert Wood Johnson Foundation and the California Healthcare Foundation for their support. And now we'll hear from our honorary chair, Senator Bill Frist, who's joining us live from Nashville, the telephonic gods willing. We're going to go to Plan B, ask the panelists to come up, and we will hear from the senator later. And we think the senator is going to say that he likes the report. Certainly signed on to it, has been writing about it. So I'd like to ask our commission members, Judy Ann Bigby, Troy Brennan, Kavita Patel, and Steve Weinberger to come up to the table. And before we start, I'd like to briefly introduce our panelists. Judy Ann Bigby is the former Secretary of Health for the Commonwealth of Massachusetts, where she led implementation of the state's health reform. Prior to becoming secretary, Dr. Bigby was a primary care physician and medical director of community health programs at Brigham and Women's Hospital in Boston. Troy Brennan, to Dr. Bigby's right, is executive vice president and chief medical officer of CVS Caremark, the largest pharmacy healthcare provider in the United States. Dr. Brennan was chief medical officer of Aetna, Inc. from 2000 to 2005, and has served as president and CEO, again, of Brigham and Women's Hospital. He was Brigham and Women's Doctors Organization. Dr. Kavita Patel is a fellow at the Brookings Institute and managing director for clinical transformation and delivery at the Engelberg Center for Healthcare Reform. She is also a practicing primary care internist at Johns Hopkins Medicine and served in the Obama administration as Director of Policy for the Office of Intergovernmental Affairs and Public Engagement in the White House. On the far left, Stephen Weinberger is Executive Vice President and Chief Executive Officer of the American College of Physicians, the ACP, a seasoned administrator and board-certified internist and pulmonologist. Dr. Weinberger has also served as faculty associate dean for medical education and professor of medicine at Harvard Medical School, and as executive vice chair of the Department of Medicine at Beth Israel Deaconess Medical Center in Boston. And we actually had some commissioners who were not from Boston. So we're going to hear some questions and answers to the panel, and then we're going to open the mics for you, but hopefully we'll hear from the senator at some point. So I'm going to ask all the panelists, what were you most excited to see in the report? Judy.
I think that one of the really important things about the report is that in many ways it maps out a timeline and a roadmap for reform. I think that one of the biggest anxieties that physicians have about this whole concept of delivery system reform and payment reform is they don't know what's going to happen between the status quo and the new paradigm. And in many ways, I think the report helps to lay that out so that physicians have some idea of what to expect, and we as a community who cares about this have some benchmarks that we can track to see whether or not we're making progress.
Steve?
I think one of the things that I'm most excited about is that ultimately I think that the things that are recommended by the report are things that will improve patient care. And one could look at this type of report as being purely related to physician payment, and although that obviously is a key part of that, underlying it, one of the underlying principles is what we need to do for payment reform really is what we need to do for patients. And I think that improving patient care, improving the way that we can deliver care is really key to this report.
I'll just add that the other aspect that was very exciting for me was just the acknowledgement that there's no one-size-fits-all, especially with respect to physicians that are in smaller practice settings, because so often we kind of gloss over and talk about very large macro system effects, and we forget that there's still a majority of people in the country that are practicing in settings with 10 or fewer physicians. So this report acknowledges kind of the wide heterogeneity of practices in our country.
It's the flip side of that. I'd say the thing I find most exciting is that it says we need to end fee-for-service, full stop. I mean, I think that that has been inherent in a lot of the discussion about sort of healthcare reform, but people haven't been as explicit as they should be about it. The fee-for-service system obviously contains an inherent inflationary factor. People who get paid more to do things will do more things. And the emphasis here is moving away from that and towards population health, and I think that's a very important contribution to the overall policy debate.
So that leads me to the next question for Kavita. Why did the commission decide it was worth in investing the time and resources to fix fee-for-service? Why are we calling both to phase it out and also to make it better?
So we've learned through the process of health reform and a number of other efforts that we often feel like we're one foot on the dock and another in a boat. The boat's about to move. I think that same has taken place in our desire to change payment reform while we're migrating and calling out a transition period of 5 years towards different models of payment and thus care. We still have to find a way to think about what we have today and what could be fixed, with the example you pointed out, Steve, with different reimbursement just based on site of service, not on quality or value of care. And so as we try to incentivize and reward value and move towards different payment models, it's very important that we actually look at what we can do right now so that we can set up the culture as well as the infrastructure necessary to further develop what we need to do to move towards blended payment, episodic or bundling payments, for example, as we call out in the report.
Anyone else want to comment on that? Okay. We say in the report that our health system is plagued by the twin ills of high cost and uneven quality. So how will these recommendations make things better, make care more efficient and also decrease costs? Anyone on the panel want to comment on that?
I think that the other panelists have said in the introductory comments how the recommendations are really geared toward making sure that we provide better care to people at a lower cost, but without really eliminating necessary services for people. The problem that we have with healthcare right now is that we pay a lot of money for some things that actually have no value or very little value in improving the health or maintaining the health of people. And with this type of reform, there is more emphasis on what are we getting as an outcome related to the actual people who are being served, not on how many things are being done or what the bottom line is for a provider or hospital, but really, does it make a difference? And there's acknowledgement that in the past, with some of the 1990s policies around HMOs and those types of payments, that there wasn't enough attention paid to quality, maintaining access, and making sure that the money was being used to care for people. So it really does incentivize the system to organize itself differently to pay attention to those outcomes.
Anyone else? Steve?
I think, in particular, the idea of transitioning from fee-for-service more towards a bundled model or a mixed model gives us the opportunity to reduce the fragmentation of care. And I think that fee-for-service with individual payments really does lead to fragmentation. And the idea that we can be paying for coordination of care through bundling, through fixed payment models, I think will both improve the quality of care as well as decrease the cost of care.
Judy, back to you. What impact does all this have on patients? How does physician payment impact them, and how would they benefit from these recommendations if they're implemented?
Well, I think there are several.
Sort of said that previously, but
Yeah.
let's amplify it.
As I said, I really believe that the system needs to reorient itself toward how we're taking care of people and how we show that they're actually benefiting from what we're doing. There are a couple of things that I think patients should notice if we're successful in this reform. Number one is they should actually have more time with their providers. Instead of paying providers for 10 or 15-minute appointments, the concept here is that we will pay physicians to take care of people, whatever that takes. So it might be a 40-minute discussion instead of a 15-minute appointment. It could be answering a phone call. It could be email. It could be coordinating the care with specialists or a hospital physician. So I think that patients should notice that, number one, they have more time with their actual physician, and that physician is not depending on the patient to be the one to figure out how the system works and what doctor they go to and who's talking to whom. The other thing that patients should notice is that there'll be more emphasis on keeping them healthy and well. Right now we pay if people end up in the hospital for things that quite frankly could have been prevented. We don't always do the best that we can to pay doctors for preventing unnecessary hospitalizations or emergency room visits. Patients should notice that these types of things are not just the natural course, but that their physicians are actually working to keep them healthy. The other thing that they should notice is that there's much more of a team approach to care, that different physicians are talking to each other about the overall general picture of a patient given a particular condition, such as a surgery or a chronic illness, and that working together, they should feel like there's somebody who knows what's going on with them and that their care is actually being better coordinated.
Anyone else want to comment on that?
I'll just add, Steve, so one trend that we've seen are kind of physicians who are frustrated because they feel like they're not able to take better care of their patients given kind of all the incentives that we point out in the report that often pit a patient versus the system in which they're in. So something that I hope will come out of this is actually kind of a culture shift in which patients will notice that physicians enjoy the environment in which they're practicing in, and that they're rewarded for the type of care that they really went to school and that we all trained to deliver. But so many times when we're caught up in cycles of measurement with productivity, and especially with these relative value units, you're often pitted against each other within the profession of medicine. And patients see many doctors feeling frustrated with practice, and some even leaving practice entirely due to these frustrations.
Yeah, I just re-emphasize the points that Judy and Kavita just made, to say that we know from years of research that financial incentives matter in healthcare. And in a fee-for-service system, at the margin, the incentive is to do more things, to do more procedures, to provide sort of more treatments. And we know that 30 to 35% of those are inappropriate or unnecessary. In a system where you're getting a fixed payment, the most important thing from a financial point of view is to make sure that that patient stays healthy. So we really turn things on its head and re-emphasize the importance of care management and systems that emphasize a fixed payment of some sort.
You're talking about how this matters to patients. Troy, with your business hat on, what's the business case for moving these recommendations forward?
Well, I think the most important part of the business case is that healthcare has to be affordable. And clearly, Steve, you and I are in the same boat when we think that what we've got right now is unsustainable. People worry, and Judy mentioned it, about sort of, well, didn't we just see this in the mid-1990s? But in the mid-1990s, we were in a much different situation with regard to the overall cost of healthcare and the ability of the government to sort of subsidize those costs. I think everyone realizes today that we can't go ahead and see further increases in the costs of the government programs. And so from the point of view of a system that's a good, affordable system, we need change, and we need relatively radical change.
Anyone else want to comment? I'm going to ask both Kavita and Steve, how does the shortage of primary care providers play into this? Why don't we just recommend that we pay primary care doctors more and specialty physicians less?
Let me start with the shortage issue. So part of what we've acknowledged, and research has actually shown, that when medical students, or even before they become medical students, are making decisions, especially given current levels of indebtedness, that they do think about compensation as part of the factors that lead to entering or not entering a career in primary care. One of the fundamental shifts that we're seeing as well is that as we move more towards a fixed payment model, for example, and Judy touched on this, as you have more time with your patients, we've actually seen, especially in regions of the country in which those payment models are predominant, we've seen an emphasis and even an excitement about entry into primary care. And it's something that takes a long time, but we know that incentives do matter, and we also know that having a culture in which people's time are valued and that time with a patient is probably of most essential value will be, I think, one of the issues that, especially as we add 31 million people to the ranks of the insured over the next years, will become even more critical, which emphasizes why we called out for a 5-year a period of time, something that's defined, in which we can give people some certainty and something to look forward to. So I can speak a little bit more after Steve comments if there's some other issues.
I think one of the things to keep in mind, and this is getting to the part of the question that says, why don't we just increase payment for primary care and decrease payment for other specialties? As with so many things today, one can apply a blunt instrument or one can have a more nuanced approach. And what really makes sense for the system is to have a nuanced approach that really recognizes value to the patient. So, for example, we do feel right now that there is less value that has been placed on E&M codes, on evaluation and management codes. But if you look at the specialties or the procedures, not all specialties and not all procedures are the same. Some of them, in fact, may be undervalued at the same time. Others may be overvalued. So we think that there needs to be, as I said, a more nuanced, more sophisticated approach to try to get the right value that is attributed to each and every one of the services that we provide.
It's important to emphasize this is not just a primary care issue. So this calibration of how we pay doctors holds for all specialties, really. Increase incentives for even high-tech specialties to do more of the technical stuff and less of the E&M services. So that we're proposing a fix that would involve all of medical care. It might help primary care doctors, but this is not really specifically directed at that. Anyone else have a comment? So back to you, Steve. We propose that we get rid of the SGR and that we pay for it with the dollar. We recoup the $138 billion with savings from the Medicare system. What would you say to people who say, "Gee, the healthcare system is already so strained, and if some of those $138 billion come from doctors, we just can't do that"?
Well, I think that the thing to keep in mind is what we all know right now, that there is a lot of waste in the system, and the number of 30 cents out of every dollar that is essentially wasted, I think, is something that needs to be kept in mind. And what we want to be able to do is to provide the right amount of care and reduce the waste and inefficiency. So what sorts of things am I talking about? Overuse and misuse of care, unnecessary services, estimated to be $210 billion. Obviously, inefficiencies within the system. I think another important area is that we need to do a better job with outpatient care to be able to reduce patients going to emergency rooms, to reduce hospitalizations, either initial hospitalization or rehospitalization. And if we could be doing a better job and remunerate physicians to be getting those kinds of quality measures, I think that we could be having not only $138 billion in savings, but actually more than that.
So there are definitely systemic-wide savings opportunities, not just in the area of, as Steve appropriately pointed out, kind of necessary or unnecessary care, as well as overutilization. We already know, for example, that in Medicare, there is a problem with readmissions. There's certainly been policies put into place that help to disincentivize any of the bounce backs that we would see within a 30-day period. But it only begs the question that there's much more opportunity if we think about hospitalizations after a 30-day period. So there is clearly, based on just even the policies and the research that we have to date, we know that there's a significant opportunity that not only makes $182 billion look like a very attainable number, but it's $138 billion, sorry, I'm making it more expensive to repeal the SGR. It not only makes it a more attainable opportunity, but it puts an imperative onto healthcare professionals that why aren't we doing it? It asks the questions, why aren't we doing this in our system? And especially when you think about the implications in Medicare for the private sector, we've seen a lot of dialogue about how whatever Medicare does, the private sector tends to follow as a policy practice. It has tremendous implication if we can identify opportunities for savings within the Medicare system. We're only creating a very intentional ripple effect in the private sector as well. And those numbers, I think that we haven't even really fully appreciated. The IOM has made some estimates about the waste in the total system, and that's far in excess of about $700 billion.
So we're not the first group to come up with recommending how to make healthcare systems better. And there's, as you know, a big gap between the proposal and the implementation. So I'm going to ask first Judy, based on your experience doing health reform in Massachusetts, what do you anticipate as the biggest hurdle to taking these pieces of paper and going forward with actually making them into flesh and blood?
So I think that's a very challenging question to answer, Steve, but I'll do my best. I just want to give a little bit of background. In August of last year, Governor Patrick signed a health care bill that basically put Massachusetts on a budget. Healthcare spending starting in 2014 is not to grow more than 3.6% of the economy. Quite frankly, that number might be very generous given what has happened in the last couple of years. But the way that the bill anticipates that the cap in spending will be contained is by implementing a lot of principles that are very consistent with what is in this report. That providers will become more integrated, they'll deliver coordinated care. The law actually mandates the Medicaid system, the state health insurance program, to move away from fee-for-service toward more global type payments. It mandates that there be efforts to better integrate primary care and behavioral health. And it also mandates some efficiencies in the system, such as using a set of quality measures that would be used across both public and private payers, and promote the use of infrastructure investments, such as the use of electronic health records. The difficulty with implementing, I think, relies on several issues. Number one, everybody knows that Massachusetts, quite frankly, is the most expensive state in the nation in terms of healthcare costs. That is in part because we have such incredible academic medical centers and advanced healthcare. Healthcare is 1 in 7 jobs in Massachusetts, so there's a lot to be said about the system that is there right now, but it is overly dependent on many of the things that we talk about in this report: specialists versus primary care, high technology versus prevention, those types of things. And moving the ship, if you will take time. I think that the things that are important for Massachusetts is that everyone is at the table: private and public payers, the business community, healthcare advocates, hospitals and physicians have all agreed that this is important and it must happen. So that is an important feature of how Massachusetts got to 98% coverage as well. The issues that I think will be hard are that we have the wrong balance of health care. But I think there's lots of opportunity to look at where we're investing resources now in Massachusetts and say this need not be the loss of jobs in the high technology end of healthcare. It could be a redistribution, retraining to get people care out of the most expensive places to lower places. And so there are lots of opportunities to reframe this not as a loss for everyone, but as a shift in balance that in the end will serve the public well. I think that the emphasis again is on making sure that people get better care, that we maintain the access that we've gained through universal coverage, and that we have a healthier population as a result. So investing in prevention and primary care, integrating behavioral health with other medical services are core features of what needs to happen. And as I said, everybody is at the table to try to implement this.
So there's some flexibility that's inherent in what we're calling for and in also what we're doing now. So we're now going to hear from Senator Frist. When he's finished, we're going to turn to Troy and ask him about the challenges to implementation that are very specific to the private sector. We have only one other question we'll ask the entire panel, and then we'll turn it over to you for questions from the floor. We've got some mics at each side. So on to Nashville. Senator, good morning. Senator, can you hear us?
I can hear you.
Great. We're ready for you to deliver your remarks. We can hear you.
I want to thank everybody for attending, and I really wish I could be there in person, but I'm pleased to be able to join by video. I know everyone there is acutely aware of how important it is for this country at this period in time to get a handle on healthcare costs. It's clearly not a partisan issue. It's not a Democratic issue or a Republican issue. It is an American issue. In fact, lawmakers on both sides of the aisle agree that current healthcare costs are unsustainable. Everybody in the room there knows it. As I travel across America speaking and interacting as a physician, as a policymaker, as a former political leader, again and again, the cost issue comes up. Clearly, we got to do something about it, and the trick comes in agreeing on exactly how best to do that, how to pull together. And this report goes a long, long way in doing just that. In just 7 years, healthcare spending is going to make up about 1/5 of our national economy, and by 2030, 1 in 5 Americans, 1 in 5, 65 or older, will be drawing on Medicare. And it really doesn't take a health economist or a brain surgeon or a heart surgeon to tell us that the current healthcare system cannot continue, simply cannot continue as it has before. We cannot control runaway medical spending without changing how doctors, how physicians in this country are paid, because it is the decisions that the doctors and physicians make that drive most expenditures for healthcare today, and that's likely to continue into the future. So without focusing on physicians and the culture and the incentives, it will be impossible, I believe, and our commission believes, to address the healthcare cost issue. As a doctor and as a surgeon, I'm well aware of the challenges inherent in making changes to our healthcare system. It has to do with our culture, the way we're trained, the way we've been brought up, the incentives in the system itself. But I also know, absolutely positive, aware that there are a lot of things that we can be doing better, from changing how physicians are paid, to improving coordination and the integration of healthcare, to the obvious transparency and lack of transparency we have in pricing and outcomes. The Commission has spent the past year, as you've heard, devising a blueprint for how best to rein in cost, while improving patient care and changing any incentives that will ultimately improve health care at the doctor-patient, at the care delivery level, how it is actually delivered. And I'm very proud to have been a part of this process. At this point, I'm calling on lawmakers and on my colleague physicians and on hospital groups, as well as the many other stakeholders, to take a very serious look at these recommendations as they hold the power to transform our system by the end of this decade. We cannot keep lamenting the physical problem facing Medicare, continued soaring healthcare costs, and a doc fix that has become an annual distraction. Every day, our healthcare sector performs technological miracles, and I've seen it in my own field of heart transplantation and cardiology, and the tremendous breakthroughs that we're seeing around the heart and around cancer and around taking care of people, around saving lives. And we've got to preserve this. We've got to keep the innovation there. We've got to keep the things that have made American medicine the best in the world. But in order to do that, we also need to focus on efficiency, on transparency, which we know is almost absent from the system, and drastically changing the current fee-for-service incentive system, a system that has outgrown its usefulness. And there was a place for it at a point in time, but it's outgrown its usefulness and now has become the single largest barrier to aligning incentives about focusing on the patient, value to the patient, better care for the patient, not just longer of life, but a higher quality of life for every dollar, every input invested. It's a pleasure for me to have been a part of the commission. Again, I'm sorry I couldn't be there with everyone in person. And let me turn it back to the chair, to the panel. But again, I appreciate everybody being there. I will be doing a lot over the coming days to share the findings of the report and answering questions as we go forward. But thank you all for being there. And again, it's been a pleasure for me to be a part.
Thanks, Senator, and thanks for the tech fix. We were talking about doc fixes. We got a tech fix today. So, nice. So, Troy, there was a question on the table for you. What are the challenges of implementation that are specific to the private sector? A lot of focus in this town is on, obviously, the federal programs, but the private sector is a big player in this.
Well, I'd say it's obviously sort of 2 points of view, one from the insurers and one from the hospitals and doctors. And from the insurers' point of view, I think the critical thing is to ensure that there are very reasonable quality measures in place. And actually, CMS has taken the lead on this with the STARS measures and Medicare Advantage program, as well as the very fulsome set of measures that they have available for the ACOs in terms of quality measures. And the private sector is emulating that. And if you look at programs like the very well-established medical home programs in Hawaii with HMSA, in Michigan with Blue Cross Blue Shield of Michigan, in Maryland with Care First, you can see that the private insurers are basically saying the same thing. We need a full set of quality measures as we roll this out to ensure that patients are getting the best possible care. From the hospitals and the doctors' point of view, the problem is the transition. You're going to have some patients who are in a medical home model, some patients who are in a capitated situation, and some patients who are in fee-for-service. So, if anything, we probably want to try to emphasize as rapid a transition as possible, because otherwise they're going to be dealing with sort of different financial incentives for different patients. In most doctors and in most hospitals, you basically want to be following one path, and the path we want to get them on is one where they're highly managing the care of the patients to make sure that everything is cost effective and that the patients are basically getting the best preventive care so as to stay healthy.
Anyone else want to comment from the private sector? Steve?
Yeah, I think one of the challenges as well is that we are trying to redesign a system at the same time we are providing care. And certainly the time issue for physicians, whether it is adoption of electronic medical records or redesigning for team-based care, all of those things end up being a challenge for physicians. Yet it's something that we have to do, and I think we're all interested in supporting physicians as they undergo these transitions.
This is the final question for the panel, so we're then going to follow that with an opportunity for you to ask questions, so be sort of thinking about those. Starting with you, Stephen, coming down, if we could only tackle one of the recommendations, one of the 12, which one would be the most important to take on first and why?
Can I answer yes? No, I think that I think that moving from fee-for-service towards bundled global payments probably is an overarching theme that I think I would put as probably the most important. I would say, though, that I do honestly think that they are all important. I'll turn it over to Kavita.
Eliminate the SGR, simply put. It's an out, as Senator Frist said, it had a very appropriate place and time, and I think that it's just an archaic notion to believe that we should still be assessing and valuing services in a fashion that has been dated back for over 30 years. And there are so many promising models in the private sector, in the public sector that have emerged from our colleagues at the VA and TRICARE. We're learning so much about how we should change medicine, and yet we still believe that we need to use a blueprint for paying for that doesn't keep up with the times. So that's the one thing we could do and should do this year even.
Well, I am going to choose an option that allows me to say that they're all important. The recommendation that we have that we focus initial efforts on those 5% who consume 50% of the resources, I think, means that we have to implement all the recommendations in order to make sure that, number one, those people are getting really great care, that they're no longer falling through the cracks, and seeing the types of outcomes that we're trying to incentivize physicians to avoid. But it also means that we can create a model that, if it works for that sickest population, we can build off of it to extend beyond that. So I think the most important thing is to focus on getting this up and running for that group of individuals and then move forward.
So it's the Sutton's Law.
That's right.
Go where the money's spent in this case.
And I would say the recommendation that perhaps is not stated as strongly, but runs through every one of the 12 recommendations, is better patient care. The emphasis here is on preventing illness, keeping patients healthy, and creating an incentive structure that really does that. And so I would say that this report is all about patient welfare and the needs to have a healthy healthcare system.
I'm going to give an answer also. You can see these answers weren't scripted. When the commission started, I thought we should spend a lot of time fixing fee-for-service because, in my sense, everybody predicts it's going to die and it keeps living. And I think in the deliberation, realized, yes, we need to fix it, but that's not the most critical thing. The most critical thing is we need to phase it out. So that's where I would stand. So we have a microphone there. If you could come up and ask your question. Say who you are and what organization you work for, and we'll try to answer those questions. Hi, Dave. How are you?
I'm Karen Domino. I'm a Robert Wood Johnson Health Policy Fellow on Ways and Means Committee. And I had a question about your recommendation concerning the RUC. And I'm just curious, you were recommending increased transparency, and why would transparency make a difference over what they already have, number one? And number two, I'm curious about the balance for the E&M codes and their methodology that they use, and don't you need to then rework the methodology, or the RUC should work their methodology to evaluate complex E&M services for people with multiple comorbidities? And I wonder if you could address a little bit about the CMS oversight, because I know there have been new primary care codes, and they've been, no action has been taken, or one of them, I recall, was actually not approved.
Questions about the RUC? I'm looking to the left-hand side of the table from my perspective.
Well, I think that what the report says is that we do need to be improving the RUC, and we do feel that that transparency is part of that, appropriate representation from different types of services based on how much they are involved in the care of patients. So, for example, we do feel that there have been some improvements made, but more improvements made for representation for primary care, for people who are coordinating care, et cetera, relative to the surgical subspecialties. And at the same time, we certainly have said that we recognize that CMS does take the RUC recommendations as a very important piece for its determination of payment. But at the same time, there is an opportunity to bring other sources in as well. And it is a very complicated issue, obviously, and within the physician community, obviously there are going to be some winners and some losers. We do feel, though, that in general the principle of transparency allows you to kind of have an honest approach as to what kinds of things should be valued, where should that value be placed. Value to the patient, as well as things such as time, et cetera. So it's the overall sense of transparency, honesty within the system, getting as many inputs as possible, we think is critical.
I'll just add, so why transparency will work is because we need a process by which the very physicians who are affected by the voting on vignettes, the vignettes themselves, and directly to what you asked around the methodology for E&M evaluation in general, that's exactly why we think this needs to be kind of unfettered. There's no reason in this day and age of open data and research that we should have that all confined within one committee. And we've already seen CMS in some cases not take up their recommendations in select areas. So we think that not only will CMS kind of, as you mentioned, either whether it's oversight or at least a little bit more direct kind of understanding as to what developed into the recommendations, CMS will have that information, will be able to make their own decisions, and everyone else who is involved in terms of the process as well as desire to have input into the process will have a better way of understanding what has largely been kind of felt to be more of a black box, and that has been the RUC's reputation thus far.
Hello, I'm Jerry Fairbrother. I'm a senior scholar at Academy Health. And I wanted the panel to speak about Medicaid. You've said that the private sector generally follows, or pointed out that the private sector follows Medicare reforms. But Medicaid is different in that it's state, federal, and it's going to get a huge influx of older, probably sicker people. It's a population with more risk factors. So I wonder if you can speak to how you see that fitting into some of this.
I think that your point is very important. Not only is Medicaid an important payer and policy setter for a particular population, but in many ways Medicaid is the only payer that pays for some of the integration and glue that makes it possible for people with very significant chronic conditions or disabilities to gain access to health care and those services that support them in the community. So I don't think that any of these principles are contrary to what needs to happen in Medicaid. In fact, with the influx of the expanded populations who are covered under Medicaid, having these types of recommendations in place will serve that population and the providers who are taking care of them well.
Would anyone else like to comment on the Medicaid issue? Okay, Dave?
David Rabin, Georgetown University School of Medicine. Under the ACO, an increasing number of people are going to be under public payment or subsidy. Physicians are paid less. Physicians react by accepting, reluctantly or not at all, some of the public payers. They may take private insurance. Private insurance will pay a bit more, but the administrative burden, particularly for primary care physicians, is increasingly distressing and discouraging, and a waste of time for primary care physicians. So I wonder if there's been any consideration of an all-payer system for physicians so that there wouldn't be disincentives to care for an increasing proportion of the U.S. population who will be on less desirable insurance options.
That issue didn't come up in our deliberations.
Should it have?
Maybe.
I'm next. I guess I'm Bob Hall with the American Academy of Pediatrics. Thanks very much for the report. It has a lot of really great ideas in it. Similar to Dr. Fairbrother, we're very interested in Medicaid. Most of the people on Medicaid are kids. They're about 20%, 25% of the cost. And so we very much appreciate the Massachusetts model that does allow for a lot of these services to flow in. In the spirit of prevention, was there much consideration of investing in the pediatric population and investing in their health so that going forward we don't have a sicker population that is dealing with the effects of obesity, dealing with the effects of asthma, other sorts of preventable conditions in children, that we could basically decrease cost over time?
I like to think that these recommendations comprise a children-friendly set of recommendations, but we didn't call out any particular population, the elderly or children or whatever. But I'm hoping that these will be children-friendly, and if your group finds ways that they're not, you should let us know. Anyone else want to comment? Judy?
I think that your comments always have to be made because we often forget kids and assume that they're healthy. But in fact, they are relatively healthy, and they aren't generally in that 5% who consume the 50, not when they're kids anyway. But your point is well taken. I think that the issue around one size does not fit all was very much a part of our conversation, and the quality measures that pediatricians might be asked to achieve will obviously be different, and they should focus on some of these preventive things that you're talking about.
And we would hope, I'll just echo that a great example of that is in pediatrics kind of reimbursement for kind of well-child visits. And that is often the lowest, most undervalued, especially in a fee-for-service setting. So taking that perfect example to scale with our recommendations, that would achieve a higher value, and the signal that would send to not only kind of the pediatrics community, but in general, that this is actually something we value, it's something parents should take seriously, something that everybody takes very seriously, will hopefully come about as a result of carrying these out. So our thought was not necessarily to concentrate on the population, but to have something that would, in the end, really ultimately result in, I think, what you were alluding to, that is a very conscious effort as a nation to place more importance in that area, which most people will tell you, my friends, my colleagues that are general pediatricians tell me, we do this because we know it's the right thing to do, but we know that we're certainly not going to feel as if it's as valued as our specialty colleagues who are performing other services that achieve different rates of reimbursement.
And the 5% who are mainly adults who generate the 50% of the costs tend to have chronic illnesses, many of which could have been prevented or postponed had they had the right pediatric care and counsel, to have them not smoke, to have them exercise, to have them keep their weight under control. So we're with you in spirit, Dr. Paul.
Hi, my name's Larry McNeely with the National Coalition on Healthcare. I work with John Rother and our board chair, Jack Lewin. I've got to say congratulations for a remarkable set of recommendations, couldn't be more aligned with the payers, providers, and consumer groups that make up our coalition, so thank you. I did want to get a little bit more of your thinking where the rubber hits the road here in these buildings around how we pay for a fixed SGR that would ideally be tied to all these reforms. You mentioned a lot of the IOM categories. Of course, it's a challenge to turn those IOM categories into federal savings. Understanding it's not part of your report, do folks have different perspectives up at the table on areas that we could go outside of, I think readmissions was mentioned earlier, the payment between outpatient and in-office facilities? What other ideas are you folks looking at?
Would like to respond to that?
Well, I'm not going to respond in terms of what can be done within these buildings. I'll respond from the personal perspective of someone who represents a physician organization, but it's quite clear that it is the professional responsibility of physicians to be using resources in a prudent fashion. And that is certainly something that has come out from a number of organizations. The professionalism charter that was written now a decade ago by the ACP Foundation, the ABIM Foundation, and the European Federation of Internal Medicine, that clearly stated that. And I think, you know, whether it's initiatives that we've been doing, the Choosing Wisely initiative, these sorts of things have to be embedded into the culture of how physicians practice. Now, it's difficult because we don't have the sledgehammer regulatory environment to do that yet, but there is more that is being done in terms of performance measures for overuse and misuse of care. And I think as those are put into play and implemented, that will certainly help.
I'll just say specifically, I mean, I touched on readmissions. We actually touch on bundling of payments. So if you take into account all the services related to, let's say, colorectal cancer care, and then think about how there is already an intrinsic desire from the oncologists and the kind of cancer care community to better coordinate their care, you could actually think about a pathway which has been tested in private sector settings right now and shows great promise. And so not only taking kind of current bundled efforts and accelerating them, but then also thinking about newer ways to group care that makes sense between transitions, like a hospital and a post-acute care setting. So those have already been identified by the Congressional Budget Office, by MedPAC. I mean, time and time again, we've seen recommendations that have not necessarily been taken up. I actually think the Congressional Budget Office's recent decrease of the amount necessary to repeal the SGR has given a great momentum for not only our recommendations, but for a number of the ideas in which professional societies have put forward. So you could argue that whether or not we can do it within the halls or whether it's feasible, there's certainly enough of a denominator there to work with now.
Let's make it happen.
Okay, sir.
Hi, my name is Neil Dube. I'm a medical student at George Washington University. I wanted to know if you all would elaborate on some of the challenges of implementing these recommendations. I know, Dr. Bigby, you discussed how optimistic you are about working in Massachusetts, but in states that are not as progressive, how do you expect to get people on board? How do you expect to get physicians on board, like cardiologists, cardiac interventionalists that are making $700,000 a year? How do you expect people that are potentially facing pay cuts from this to essentially get their support? And, when you don't have people's support and you want to make them do something, sign it in the law, is that something you guys are planning on doing? Or, sorry, I know I threw a lot at you there, but if you could address any of those, I'd appreciate it.
So just to clarify, we are not recommending any legislation, but we are hoping that those who are involved in making policy decisions will find this report very useful. But with that as a preamble, I'll have to say, when I was summarizing my experience at the Robert Johnson Foundation, one of the phrases I said was execution trumps strategy, and you're just basically saying that. So comments on hurdles, challenges, politics, special interest groups?
I think your question is necessary, but I think it's way too narrow. If we think about, if it's true that 30 cents out of every healthcare dollar is not necessary, that doesn't, and if we want to move toward a system where we are saying to physicians specifically, since this report is about physician payment, we don't want to pay you for every stent you put in, or every 15-minute appointment you see, or every MRI that you ordered. We want to pay you for a patient who doesn't develop chest pain, doesn't get readmitted after a acute MI, and we want to pay people for that care. I think that there's more than enough money in health care if 30 cents of every dollar is being wasted, and we're not paying for the right things at this point. I think that as physicians look at what they're achieving, they will have to re-examine how they get to whatever revenue they want to get to, but we certainly need to be very clear about what the incentives should be and use that as the starting point.
Anyone else want to add to that?
I just say you can see it in a lot of places today. There's a lot of healthcare, especially sort of towards the West Coast, where people are paid on basically a sort of capitated basis, and they've developed systems to try to create better preventive care and lower overall rates of invasive procedures and things like that. And in markets, in particular our market in Boston, for example, the big physician organizations are basically sort of bending to what's happening with regard to payment. Payment's coming through more and more in a global capitation, and that's what they're taking from the private health insurers. And you can see all of them jumping into the ACO program on the Medicare side, because they're beginning to sort of put the incentives in place to be able to sort of manage care and prevent illness and encourage health. So I think people will bend to the incentives that are set forth in the system, and we'll all do quite well.
Steve, I want to thank you as a medical student for coming to something like this, because I certainly did not think about these issues as much as I probably should have when I was a medical student. But I'm from Texas, and so I think a lot about how all my friends from medical school would react to this report. And I think from a strategic point of view, I would say that something that we called out, that there needs to be some period of assistance as well as guidance for small practices to figure out how to do this. I think it'll deal with some of the issues you brought up, and even more specifically, building on Troy's point, I know a lot of small practices that have kind of said, we still want to maintain our independence, but for the purposes of coming together around an accountable care organization, they're actually kind of forming relationships with each other. And lo and behold, they're finding that they actually are benefiting from that financially, to the extent that they can figure out how to work together, share information. So I think some of these things have to be considered kind of in process with some of the other advances that we have, like meaningful use and the emphasis around expanding our kind of use of electronic health records. And I know that those are all challenges physicians are facing right now in real time, but as we think about migrating payment and the example with an interventional cardiologist, I would go back and I would almost ask that interventional cardiologist, do you feel like you're doing everything absolutely that you could be doing to provide the best care to your patients? And in many of the cases, those cardiologists will tell you, frankly, actually I'm frustrated, and what I'd like to figure out how to do is better work with all the various people that send patients to me or that don't need to be sending patients to me. And so I think more then often you'll find that the profession of medicine is willing to rise and say, you know what, we want something better, and I think this is one of those times.
We have time for the final two questions.
Hi, I'm James Lightfoot. I work for Emergency Medicine Associates, and my question is, I have a question and a comment. The comment is, part of that 30 cents wasted, some sort of tort reform is going to have to be involved if you want to save some of the wasted care that's done. But my question is, what's going to be the role of emergency physicians with these recommendations?
Take care of emergencies.
Well, let me add to that. I think it may sound like a glib answer, but that is absolutely right. That there is a huge use of the emergency room right now that represents a failure of ambulatory care. That is in terms of access to care, off-hours access to care. It is in terms of coordination of care when there is not a primary care physician who is able to take care of a primary care physician to whom the patients can turn when they have a problem. So I totally agree with Judy that you as emergency room physicians should be doing the kinds of things that we think of when we think of emergency medicine care. It's not your fault. It's the fault of the system right now, and we have to revamp the system, revamp the remuneration, the payment, et cetera, so that we have better primary care, better access to care, better coordination of care.
But how are we going to get paid with this model? Physician reimbursement, how does that going to apply to emergency physicians? What's going to happen with us? I mean, we can't keep people out of the hospital. They're there once they're there for us.
I think that emergency departments and emergency department physicians and other providers are seen in this as part of a system, and they certainly play an important role in that system, and they will be paid. I think this is the whole issue about the integrated systems, the ACOs, having a mechanism to support the physicians and other providers who are necessary to deliver the care in that system. So this is not suggesting that emergency physicians should be penalized for unnecessary visits or that sort of thing, because quite frankly, by law, you're mandated to see whoever shows up. But as Steve said, it is often that people show up because the rest of the system has failed.
Okay, thank you.
Final question.
Speaking of primary care, I'm Reed Blackwelder, President-elect of the American Academy of Family Physicians. So really appreciate the excellent work of the Commission. Also appreciate the last few questions leading toward the recognition this is about ultimately better patient care, which is primary care, which is using emergency rooms for what it's needed for, using cardiology service for what happens when primary care doesn't work. We had similar recommendations from a task force that we formed in 2011, and there are a lot of voices now that I think are starting to speak together, which hopefully can move the needle, because we want to inform policymakers, but we'd like to see policy shift. In addition, MedPAC had some suggestions as well. I was just curious as to what you as the Commission see as the difference between these recommendations and MedPAC.
Well, one is that MedPAC only comments on the public sector, and we comment on both the public and the private sector. A second is the site-specific payment, the very great gaps. I don't believe that they've commented on that, but I wonder if Kavita, who is probably the closest to all this stuff, might want to comment.
So there are definitely a lot of overlaps with not only your report as well as a number of other recommendations and reports that had been made. The only thing I would say in addition to what's not or is addressed by MedPAC is that we've called for a very definitive time period and then also talked and acknowledged at the same time to fix fee-for-service now while transitioning to that. So I think while that also is still something that a number of legislative proposals, recommendation bodies have touched upon, I think it's pretty clear, it's crystal clear in our recommendations that, despite whatever the political ambitions might be, we have to do this now for a variety of reasons. So I would call that out as kind of something that was front and center, and you've seen other bodies try to tackle how we do it. We tried to deal with everything, both in the public, private, as well as the timeline.
So this is the end of our formal presentation. Rather than try to summarize what has been a very complex set of issues, let me just close by putting it in a framework. I've been around a long time this issue has been around a long time, and in the past, whenever reining in costs rose as an issue, there would be some temporary belt tightening with the understanding that you could loosen the belts after the pressure came off. I don't think that is any longer viable. I think we're almost at 20% of GDP, and the hope that this issue is going to go away and it's just a flurry because of this or that, I think those days are over. And I think it's going to be a challenge to those working in the system and those charged with making the system better, but we've got to accept that challenge because the current system isn't sustainable. So with that, I want to thank you, our audience, and our panelists for an informative and lively discussion, and hand the podium over to Dr. Harry Selker, President of SGIM, the sponsoring organization for this, who's going to give closing remarks.
Thank you all for coming to hear about this Commission's report, and thank you particularly to the Commission and to Steve, Kavita, Judy-Ann, Troy, and especially Steve Schroeder. You can see how he ran the Robert Wood Johnson Foundation when you see the way he ran this Commission. It was an awesome thing to behold. They all worked really, really hard, and he made sure of that as their ringleader. Society of General Internal Medicine is about 3,300 leaders in general academic medicine worldwide, and we as clinicians, teachers, and researchers realized that this was something that ought to be taken on, and we also realized that we were not individually or even as an organization the right group to do that. So with some anxiety, we in fact handed it over to a commission about which we had no control. There's members of every stakeholder group that you could imagine in physician payment, and they did a great job, as you'll see in their report. They obviously were addressing what we saw as general internists as being a core twin obligations. We care deeply about our patients in front of us. We want to be sure they get the best care possible. We also are stewards of society's resources, and those sometimes seemed that they were in opposition, and that obviously can't go on forever, as has been well stated. Everybody cares about improving personal care, population care, and also containing costs. The Commission has a really, I think, a very practical set of recommendations to try to make that happen. You may be surprised to know there's no switch that actually makes that happen. This is really an opportunity, these recommendations, for others to take it and put it in place and make it work, obviously right in this very particular location as well as elsewhere. It's not going to happen by itself, so it's really kind of a work order for us all to work upon. I'm particularly hoping that those in the room who will think hard about this will maybe make suggestions for improvements as they try to implement them. I don't think I have to explain to anybody here why these are so important. Ultimately, one of the things we wanted to have happen is as opposed to in the 1990s when capitation came out and it looked like there was a way to contain health care, but we felt frankly awkward talking to our patients about it face to face about what was really going on about costs. The idea of transparency and a rational, fair way of allocating these valuable resources in a way that our public is engaged and comfortable and understands the incentives, that's really what we'd like to have happen, as well as a way that is responsible. I'm enormously grateful to the Commission. They worked really hard at this. People who are way too busy. I'm particularly also appreciative of Dr. Senator Frist for weighing in. Not only did he represent, obviously, his experience, but also as a surgeon, and also I think I don't have to explain to you that he obviously understands very acutely how important this is. So mainly SGIM, Society of General Internal Medicine, thanks the Commission for its work, and obviously we, like all of the people in this room, I suspect, will do whatever we can to help it be implemented. Thank you.
Thank you very much.